It's time for us to start our meeting. We've already formed a quorum, and it's also time for us to start. Let's start, all right? Welcome, members, to this special meeting of the panel on health services on issues relating to the development and operation of private hospitals. The paper from the administration and the background brief prepared by the Legislative Secretariat have already been distributed to you. Please invite the government representatives to come in. Well, this meeting is a bit different from the PAC meeting. We've invited representatives from the private hospitals, altogether 8 of them. So we'll listen to their views or explanation to see how they're operating at the moment. Please also invite the deputations to come in. Welcome, Bureau Director and representatives from the private hospitals. In a moment, I'll invite the deputations to speak first. I think about 3 minutes each. Perhaps I should remind you that your verbal remarks and written submissions are not protected by the Electoral Powers and Privileges Ordinance. In other words, you have to bear your own legal responsibility. Now for your earpiece, channel 0 is Floor, channel 1 is Cantonese, and channel 2 is English. It doesn't matter if some of the deputations choose to speak in English. You don't have to tell me. You just start to speak. All right, speaking time, 3 minutes. Please be concise as far as possible. First of all, we have from the Evangel Hospital, Dr. An Kwan. I'd like to thank Dr. Lau for according us this opportunity to say something on our experience. Private hospitals take up a very small percentage of medical and healthcare services in Hong Kong. Nevertheless, we're able to contribute to the healthcare services of Hong Kong. Evangel Hospital is a private hospital. Therefore, for services provided by public hospitals and private hospitals, the Evangel Hospital has been able to meet certain needs in a number of areas. For example, non-emergency services like medium and small-scale surgery. Demand is high, but waiting time is long in public hospitals. So our hospital is providing another choice to the patients so that they'll get expeditious treatment and go back to work as soon as possible. Another area of service is medical checkups and general tests. Well, these are general in nature and involve high-tech, like computer scanning, MRI, and so forth, such that before patients reach a very serious stage, they'll be able to obtain expeditious tests and checks, thus leading to timely treatment. Thirdly, we operate health centers at different locations. We have community clinics, for example, for the lower income public in order to serve them. To sum up, our hospital is of the view that our hospital is just like other entities in the healthcare system of Hong Kong. Because of the aging population, there's a huge demand for medical and healthcare services. And members of the public have higher and higher expectations for healthcare services in terms of quality. So our hospital would like to make corresponding arrangements for them. Next speaker. Oh, Mr. Wong has not arrived. Then Dr. Wong Pak-kwan, Medical Superintendent of Precious Blood Hospital. Dr. Leong, I'd like to say that in the past 12 years, private hospitals have contributed a great deal to accreditation. We started 12 years ago. In fact, in terms of hospital management, patient treatment, and staff training, we've made great improvement. I believe this can be witnessed by all. We've joined the Australian accreditation scheme. I believe that will take us a step further. Many people have criticized private hospitals for insufficient transparency. But at least insofar as Precious Blood Hospital is concerned, as far as fees and charges are concerned, although we're unable to tell patients on admission all exact fees and charges for every item, because an item may cost thousands of dollars or over $10,000. So it's impossible for us to tell patients upon admission all the fees and charges. But medication and operational costs will be made known to patients. So we've actually made huge improvement. Finally, we agree that there should be legislative amendments to raise standards and quality of service. That's beyond doubt. Thank you. Next, Union Hospital, Deputy Medical Director, Dr. Aris Leung. Thank you, Mr. Chairman. Thank you, members. As Hong Kong society becomes wealthier and private medical insurance keeps developing, private hospitals will be able to contribute a great deal to society, and Union Hospital is all for legislative amendments. Union Hospital is a private entity. We're different from non-government organizations. We have to complete our own mission and tasks, and we also have social responsibilities. So society should view us differently from NGOs, and all these are reflected in our licensing conditions. Now, we attach importance to a number of documents. First of all, the Code of Practice for staff members. Secondly, patients' privacy. These two are cornerstones of our society which must not be readily given up. So doctors and healthcare personnel should have sufficient room to decide how to treat their patients. I believe the majority of healthcare workers in Hong Kong are doing that. Private hospitals are responsible for managing the hardware, personnel, software, and systems of the hospitals. They have responsibilities and obligations and powers. including the dedicated functions and efficacy of doctors. We have to look forward and look back insofar as peer review is concerned. Private hospitals are duty-bound to establish regimes and measures such that healthcare personnel can complete social missions. And every private hospital should have complete systems to allow the staff to keep a vigilant eye on all these. The administration, including the government and the Department of Health, should monitor our systems instead of the details therein, because society cannot provide sufficient manpower to look at each and every detail. Rather, we should look at the systems behind every incident, whether everything is covered, whether there are mechanisms to cover everything, and whether there are methods to make improvement. For each medical incident, be it a good one or a bad one, we should be forward-looking and look into the educational value of the incident instead of doing witch hunting. That shouldn't be encouraged in society. We should learn from one another. As for other aspects, we should adopt one single yardstick for public and private sectors. And between the public and private sectors, there should be enough communication and collaboration in terms of treating patients. That will benefit Hong Kong society. Next, Matilda International Hospital. The Executive Director for Finance and Administration, Mr. Steve Au. Mr. Chairman, members, what I would like to say is about the operation of a hospital. Every year, the Department of Health requires all private hospitals to fill in a 200-page report under our licensing conditions. I hope that in future, electronic applications can be considered, because every year we're just repeating and repeating what we've done before. As for the licensing regime, reports should be submitted biannually or even triennially rather than annually. And there is also an annual audit by the Department of Health. Tick box and checklist approaches have been adopted more and more. Now, many private hospitals have joined the Australian accreditation scheme, which emphasizes safety. So, can the administration consider changing the regulatory method? As for human resources, in Matilda, our patients are a bit different. Every year, we very often have to recruit personnel, healthcare personnel from overseas, and usually it takes a year to a year and a half to bring them in. We may have 10 applicants at the beginning, but end up with one successful candidate who actually comes to Hong Kong to assume duty. We did reflect to the Department of Health that we should discuss with the Nursing Council whether there can be a compromise. That is, can examinations be sat electronically rather than bringing in the candidates from overseas to sit for written examinations.
Next, from Canossa Hospital, Caritas, Dr. Thomas Yun, Director Medical Services of Caritas Hong Kong Management Company of Canossa Hospital, Caritas. Thank you. I'd like to refer to the panel's paper. Well, very often there are a lot of suggestions, and I'd like to give our response. In future, in terms of the healthcare sector in Hong Kong, Hong Kong's population will increase to 8 million people, and there will be 300,000 elderly people in our population. So demand will definitely be increasing. So there should be collaboration between the private and public healthcare sector, and long-term planning for private healthcare services are also required, because huge investment is required. In terms of manpower, the Steering Committee on Manpower Planning of nurses and doctors, well, private practitioners should also be taken into account because of the huge number of beds in private hospitals. Whenever we encounter a manpower shortage, they will accuse us of draining away the manpower. And there should be proper manpower planning so that there won't be a huge surge of salaries. And in terms of charges, there are special packages or packaged charging. And hospitals are encouraged to adopt packaged charges. But sometimes packaged charges are very often less costly, and large hospitals, because of their good business, may not want to adopt package charging. For smaller hospitals like our hospital, we don't mind offering package charges. So if you encourage hospitals to offer package charge services, that might yield better results. For example, subsidies can be provided to the middle class, or for patients waiting on the long waiting list of HA, and also for low-income earning patients who would like to resort to private healthcare services. They can make use of the subsidies. This is a very good suggestion for private-public healthcare collaboration. If there are too many restrictions, for example, the number of obstetric beds are restricted to no more than 20%, then this is not very good, because this service actually helps development of private hospitals. If you impose this restriction of no more than 20% of the total number of beds, then maybe demand will come down eventually. This should be left for the market to decide. Thank you. Next, Dr. Raymond Yong Wai Hong, Assistant Medical Superintendent. Chairman, members, Secretary, fellow members, good afternoon. We're here today to talk about development of private hospitals and the regulatory regime for private hospitals in the future. Now, over the past decade, we have seen these examples. When we look at the percentage of private healthcare services in terms of the overall sector, and also when we look at the quality of private healthcare services, the quality has kept improving, so our position is getting more and more important. There are items not currently being offered by public hospitals. For example, cosmetic surgeries or eyesight correction surgeries or other testings, and we do offer such services. So in future, when these services are to be regulated, we have several suggestions. First of all, at present, the regulation on private hospitals is already very stringent, because we need to go through the Lands Department, Planning Department, the Department of Health, and also the RKSD, and seek their approval before we can proceed. So when we plan ahead, we should bear in mind the principle that I've just said. That is, patients should be given the choice and the time for carrying out the operation, etc. And the private hospitals can also be a training ground for medical personnel. At present, the public hospitals are the main training ground for medical personnel, and in the course, more exchange with the private sector should be carried out, and these professionals should be allowed to work in private hospitals for a period of time so that they understand the practice in the private sector. And in terms of the use of equipment, we also hope that there will be more information exchange. For example, as far as X-ray is concerned, we already have exchange of information. So we look forward to more exchange in terms of manpower training. Now, when we recruit expatriates and when we conduct training for them, it's very difficult. Training is particularly difficult. So in future, we should consider allowing private hospitals to take up the role of as trainers. Next, Dr. Anthony Lee, Chairman of the Hong Kong Private Hospitals Association. Chairman, members, representatives of the administration and fellow members, good afternoon. I would like to express our views on behalf of the Hong Kong Private Hospitals Association. Earlier, we already submitted a paper expressing our views. We have 5 points to make. First of all, as far as health services are concerned, the government should have a long-term vision and mission to implement the relevant policy. We feel that the voluntary health protection scheme proposed during the last term of government is good for Hong Kong, because Hong Kong is a diversified society and some people can afford such services. They should be given more options as to whether to take out a service from private or public sector. And private and public hospitals are, in fact, cooperating partners. Private hospitals take up a small percentage of patients, and we can deepen this relationship. For example, in Australia, there are private doctors who can still play a role in public hospitals. As for regulation of private hospitals, my fellow members already add some views. We agree that the regulation should be tightened up, but the Department of Health in regulating private hospitals should act as a collaborating partner of private hospitals. That is to say, we should work together in enhancing the service standards and the quality of service, rather than playing a role similar to the Correctional Services Department. Point number 4, during the last term of government, there was a proposal about the development of medical tourism. But this is no simple matter. We need more training. We need training of professionals and also other allied healthcare professionals. And the government should not solely rely on the HA's hospitals. There should be separate training schemes in the public and private sectors. As for financing, as I said just now, the health protection scheme does offer a mechanism to have control over pricing. Thank you. So may I invite the administration to take us through the administration's paper and see if they have any preliminary response to the deputation's views. Thank you, Chairman, for arranging for today's meeting, so that apart from hearing members' views, we're also able to hear the views from private hospitals on the regulation of private hospitals in the future. It is very important to our work As for the existing regulatory framework for the operation of private hospitals, including the reporting of sentinel events and financial management and procurement procedures of private hospitals and transparency of charges of private hospitals, all these are covered in the paper already. I won't repeat them. Anyway, we agree that there is room for improving the existing regulatory framework, and therefore the administration has started its work in reviewing the relevant legislation, including CAP 185. And as you may be aware, we have established a steering committee in relation to this matter, and the first meeting was convened on the 2nd of November this year, and the committee decided to set up 4 working groups at the meeting. One of them is to review the regulation of private hospitals. The working group is chaired by the Permanent Secretary for Food and Health, with members coming from public and private healthcare sectors, as well as representatives of patients, associations, etc. And after collating views, within the second half of 2013, the working group would submit its findings to a steering committee. Followed by that, the consultation process would be kick-started. Today, we have released a press release on the appointment to the working group on regulation of private hospitals. Lastly, I'd like to talk about the development of private hospitals. For the 2 sites earmarked for private hospitals development in Tai Po and Mong Chuk Hang, the tendering process already ended in the end of July, and now the administration's tendering committee is scrutinizing the tender documents, and the results will be announced in the first quarter of next year. And having regard to the experience of the tender exercises and the aspirations of the community, we will consider the way forward for private hospital development. I think I will reserve some time for members or deputations to ask questions or give comments. All right? So the floor will be open for members to ask questions. Dr. Ka-lau, Chen Han Pan, and other members. So please try to be concise when you ask your question. If you have time left, you can follow up on the administration's answers. So 4 minutes each. First member, Dr. Ka-lau. Thank you, Chairman. First of all, I'd like to thank the deputations for coming and giving their views. I'd like to ask Secretary. Now, we understand that there is a huge concern recently. Now, the private hospitals are saying that the existing regulatory framework is more than sufficient, or even going a bit too far. But as far as the administration is concerned, I don't see a very clear framework or the way forward. Well, Secretary, of course, you have established a committee and a working group, and you have announced the composition today, but I'd like to know more on the framework so as to reassure the public.
And during the last CE's question time, one of the questions was about the profits and reserves of private hospitals. We all know that those could be as high as 25% of their operational costs, and some of them have actually accumulated a reserve of over $2 billion. However, some of them are operating as charitable organizations. Transparency is one aspect. Where the money has gone is another. We all know that the land being used by private hospitals, say for a minority of them, which have been used to develop luxury residential flats. Well, most land sites were actually tendered I do not agree that those land sites are private assets. They're public assets. I think we should build in sufficient safeguards for the public in their fee structure. 20 to 30% of operational profits are unacceptable for charitable organizations. I can't see how your framework can assist the public in terms of the fee standards. Secretary, well, as far as I could hear from the honourable member, there are 3 to 4 aspects in his question. First of all, about subsidy. I noted that private hospitals had expressed their views on regulation. I think we all agree that the regulatory framework should be reviewed. The legislations involved should also be reviewed. Whether or not those are sufficient, we heard from the private hospitals that they do not want micro-regulation. We agree. And the Department of Health is not capable of micromanagement of private hospitals. So that's not what we meant. But we do have a statutory duty to regulate them. And in the course of consultation, we understand that the majority of public views points to insufficient regulation. The legislations involved have not been reviewed for over 10 years. We're often asked what conditions should be satisfied before we give license to a private hospital. It's hardware, manpower, and equipment. But that's a macro-management approach. All along, the Department of Health has been regulating private hospitals. Some of the private hospitals were saying just now that we adopt a checklist system. Now, we don't want to adopt a micro approach. First of all, we have to examine whether their frameworks are tidy. Secondly, we look at operations. In particular, for some private hospitals, their land grants have exerted constraints on their proceeds, which have to be plowed back to the hospital concerned. We're now obtaining financial data from the private hospitals to be analyzed by the Lands Department. Just now, our colleagues from private hospitals pointed out that members of the public would like to see a higher degree of transparency. That's normal. But our colleagues also pointed out that for comprehensive regulation, if we require a certain amount of services to be provided in package forms, there may be problems. Packages must be selective only in terms of delivery of babies and operations as far as possible. Later, we'll discuss more with private hospitals whether or not the degree of transparency of the fee structure can be further enhanced on that foundation so as to satisfy public demands. You've not told us anything about the high level of profits at the moment and the rate of return now stands at 20 to 30%. Does that satisfy the definition of charitable organization? Sorry, we have 1.5 hours. I believe we have sufficient time today, so please wait for your second turn. Mr. Chen Han Pen, just now I heard from the representatives of the private hospitals that in future they would accept regulation by the administration. For members of the public, they have 2 major doubts about private hospitals. First of all, prices have been fluctuating. Let me cite an example. My child was born over 2 years ago. The gynecology and obstetric services fees were very different from what they are now. And private hospitals are using Hong Kong's land resources. Do we have methods to ensure that private hospitals apply different fees and charges to Hong Kong residents than to non-Hong Kong residents. That's number one. Number two, there's a huge imbalance between the public and private sectors. In particular, it's common that the public sector and the private sector are competing for human resources. When a new private hospital opens, it uses high salaries to attract personnel from the public sector. Has the administration estimated the future demand for manpower, and what solutions do we have to ease the shortage of manpower? These are my two questions. Secretary, Mr. Chen asked two questions. First of all, about fees and charges. Up to this moment, policy-wise, for private hospitals, they mainly have their own separate market, so we won't regulate the fees and charges of private hospitals. If we have granted a land site to a private hospital, and if there is a premium discount for that private hospital, then in the land grant for that hospital, there is clear stipulation that proceeds have to be plowed back to the services of the hospital concerned. Whether or not we've performed well in this regard, we'll try to make improvement. Anyway, we're not going to control the fees and charges of private hospitals. What we're concerned about is the transparency of the fee structure, because it's basically the patient's choice when it comes to private hospitals. If the degree of transparency is enhanced, patients will be left alone to make their own choices. Secondly, in relation to manpower, we've already set up a steering group to review manpower issues, and the steering committee is already operating. We hope that the steering committee can assist us in establishing a framework, as pointed out by the private hospitals just now, to formulate a formula to meet the future upward and downward adjustments of our population size, our aging population, our expansion plan for private hospitals, the changes to be effected to our healthcare system, etc., etc., such that in the long run, we can more accurately estimate our manpower demands in the next 10 years, 20 years, or 30 years. But of course, we won't be 100% perfect, but we'll try our very best. Next, Dr. Joseph Lee. Thank you, Mr. Chairman. I'd like to thank the private hospitals for coming to state their own situation. But of course, there are so many details that we cannot put everything on record. But one thing is very strange. In paragraph 10 of the administration's paper, a code is mentioned. It said that from 2009 to November 2012, the administration detected no non-compliance by private hospitals. What do you mean by no non-compliance? Understand that the code was first published in 2003-06. For example, fees and charges have to be made known to patients upon admission. Why is it that there's no non-compliant case? I know the private hospitals are willing to be regulated. The legislations may be outdated already. There are things that you're unable to do. So it's good to have discussions. Yet, at this stage, the Department of Health has not been performing well enough in their inspections. What can be done then? For the fee structure, if there's insufficient transparency, what can you do to enhance transparency? I may not buy a package of services. When I go to a private hospital, well, I may patronize Dr. Ka-lau. The hospital should tell me the room charges, the operational charges, etc., etc. So I suspect that in terms of transparency of the fee structure, you should do more. We may have to wait for a couple of years before legislative amendments come forth. So you should have transparency. You should tell the public what can be done and what not. So we must not have fluctuating prices. Number one, that is. For number two, the low-charge beds. Even now, I don't understand what's happening. It's not mentioned in the paper. In the land grant, if it is stipulated that low-charge beds should be provided, then the private hospital concerned is duty-bound to provide those beds. Failing that, the private hospital is duty-bound to tell its customers the reasons. For example, the beds are full. So can we have enhanced transparency for these beds? Say if I go to hospital A, there will be low-charge beds, but for hospital B, low-charge beds are not stipulated in the land grant. But here, I don't see the DH do this. So, Secretary, at least you need 2 years to effect legislative amendments. The DH has not been performing well enough under the statutory regime. Under the code, you have to conduct inspections. So in the next 2 years, what can you do to set our minds at ease? Well, Dr. Lee's questions can be divided into 2 parts. The first part is related to fees and charges. I think you're correct in pointing out that if private hospitals are to make their fees and charges transparent, they only need to publish a list. But can that list satisfy members of the public such that they can master the fees and charges concerned? Well, the list can set out fees and charges, but patients ask for more. They want predictability. That is, as far as possible, upon admission to a hospital, I would like to know roughly what fees and charges I have to pay. Now, not just we have difficulties. Private hospitals also have difficulties. As I mentioned, say for selective operations, for the ONG services, if the patient opts for a package, there can be certainty in terms of fees and charges. But say if a patient complains of stomach ache or belly pain, tests have to be conducted first before fees and charges can be known. So a number of tasks have to be performed before the patient can know his budget.
The second point is about low-charge beds, and we agree that we definitely have the responsibility of monitoring private hospitals in this matter so that patients using such service can stand to benefit. But the fact is, over the past, the private hospitals have been offering low-charge beds, but did the patients really benefit from the service? If the responsibility is about the provision of information, for example, making available a statement, then this is not sufficient. If you really want to help patients patronize and use the beds, we need more work. They need to know that such beds exist so that they can apply for such beds at the time of admission. And the hospitals should also remind patients that they can apply for the use of these beds. And you cannot guarantee that definitely there will be a high utilization rate. What if nobody or few people apply for such beds? And what if private hospitals are covered by insurance? So for private hospitals offering low-charge beds, we need to work with them on a number of matters, and we might also need to work with the hospital authority so that some patients can be transferred to such private hospitals and benefit from the use of low-charge beds. So we have a number of works to do. Well, Secretary's answer is quite peculiar. I will follow up on his answer if I have the opportunity in a moment. Dr. Fernando Cheung. Thank you, Chairman. Thank you, representatives of private hospitals and the association for coming to this meeting. Now, after the release of the audit report, there has been repercussions in the community. Private hospitals, many of them are charitable organizations. They don't need to pay tax. They only need to pay nominal premium before they get the land grant. And under such arrangement, you see that they are reaping huge profits. Some private hospitals have turned part of their sites into luxurious residential developments. Some of the hospitals have transferred their profits to, for example, the parent organizations or even private companies to reap the profit. So it is very different from what the public has expected. Now, our direction, at the time, Mr. Donald Tsang proposed 6 pillar industries, and we're still heading this direction. At least as far as our land policy is concerned, we're still heading this direction. And we're going to follow up on medical financing in the future. We have been discussing this matter for a number of years. The administration has proposed a private health protection scheme with $50 billion allocated to address the imbalance between private and public healthcare sectors. In other words, more patients would, under this arrangement, opt for private healthcare services. However, we see clearly that from this operation, private hospitals are making huge profits. But in the end, could the patients stand to benefit? No, because many of these beds have turned into first-class wards, private wards and daycare centers. So it's really a huge concern that I have. So my question for the deputations is this. The private hospitals have been making huge profits in the past. I understand that this may not be their main objective in mind, but do they have any papers to explain to the public about the use of the profits generated? And a question for the administration. If the administration is continuing with the direction of developing healthcare as one of the industries where Hong Kong enjoys clear advantages, and more resources will be allocated to private hospitals. Now, are we still heading in this direction, and will this be affected? And what about re-registration? Private hospitals are required to abide by the land grant conditions or the conditions imposed on them as charitable organizations. First question of yours is about the plan of private hospitals in making use of the profits. And the second question is for the administration, and it's about the future direction of the development of healthcare sector. So as I understand, there are 2 hospitals. The Union Hospital is profit-making. You can answer this question, if you will. Now, I'll try to answer Dr. Cheung's question in my capacity as chairman of Hong Kong Private Hospitals Association. First of all, some private hospitals are not run by charitable organizations or religious bodies. So the land that the land grant that they got is in fact for profit-making purpose. And that's the practice across the world. For private hospitals, there are profit-making hospitals as well as non-profit-making hospitals. If you're running a business, you will make money or you lose money. And as far as I understand, quite a lot of hospitals suffered huge losses during the SARS outbreak. And for Union Hospital, it started operation in 1995, and for the audited account, up to 2001, annually, it incurred a loss of $100 million. So at that time, if they had not come up with any ways to survive, wouldn't it mean that the hospital would have to be closed down? And that was the reason why they reserved part of their site for property development. This example is rare. It's about a business decision. It's about survival of a business. For other hospitals, I understand that there are hospitals making huge profits. They have huge profits sitting on their reserve. I understand that during the SARS outbreak, they also suffered losses. So when they have made money, there should be more in the reserve, and it's understandable because we don't know when another outbreak similar to the SARS outbreak would happen in Hong Kong. Now, in terms of fees and charges, I'd like to clarify this point. A member just now said that the fees and charges fluctuated. Well, in fact, he quoted the example of prices going up from 2 years ago, but this is not about the fluctuation of charges. Now, for the charging of our private hospitals, we do have transparency. I think Dr. Ko, our secretary, also mentioned this point. That is whether it's feasible for us to do so. We cannot operate like a restaurant. We cannot state that for this dish, the price is so and so. We cannot. We cannot say that for beef, the price is so and so, the noodles, the cost is so and so, and also for the wage cost is so and so. We cannot do that because we have different doctors. Now, these are real examples. Some doctors may take 1 hour to finish one operation. Some other doctors may take 2 hours. So there is a difference in terms of the cost of operation. And that's why we can only rely on the average sum if we are to offer packaged charges. So it's impossible for us to give a very clear idea of the exact charges. And for operations, there are risks. There may be complications, and these may happen out of the expectation. For example, some procedures will have to be carried out to stop bleeding, and this may attract extra costs. So when the community criticizes private hospitals for the lack of transparency of charges, I can say that we can tell patients that for a certain kind of service, the charge is so and so. But the fact is, we're not concealing any fact. You'll be given time to follow up, probably in the second round. Administration, development of the sector, or industrialization. Thank you, Chairman. In Hong Kong, as far as our standard of healthcare services and the regulation on the healthcare sector is concerned, we agree that our standards are comparable to international standards, and that's why we have this proposal of developing the healthcare sector. In other countries, the healthcare services account for quite a huge share of their GDP. Setting aside GDP, the sector also takes up a certain percentage of our total manpower. But after the incident of mainland couples coming to Hong Kong to give birth, we can see from this example that under our existing regulatory framework, we do not have much capacity to accommodate them. If we're talking about developing the industry, we're actually talking about increasing our capacity to attract people outside the territory to come and patronize our service. And in turn, to help us generate income. But we do not have this capacity because we understand that for public hospitals, supply is already short. So as far as capacity is concerned, we do not have much spare capacity. So development of healthcare sector should be done prudently. Now for the 2 sites for private hospitals development that have already undergone the tendering process, we will look at the situation and the market response and the manpower situation. We will be prudent in terms of development of private hospitals. Well, it is necessary to develop private hospitals. Without private hospitals, we will only have public hospitals, and since it's highly subsidized, definitely there will be a problem. So it is very important for us to develop private hospitals. But in this regard, I take a prudent view. Dr. Elizabeth Quat. Just now, some members already asked about fees and charges. So my question for the administration is, in future, what do you have in mind? On the one hand, you want more patients to patronize public hospital services. But now the development of private hospitals is quite stagnant, and the fees and charges are quite high. So if you want to facilitate more patients in making use of the private hospital beds, you still may not be able to resolve the problem of diverging patients to private healthcare services. So do you have any measures, or what measures do you have in facilitating patients to use private hospital services? And if you, when you approve land grant for private hospitals, will there be any difference between profit-making private hospitals and non-profit-making ones?
Another question is about the notification system for medical events. I'd like to understand more about the system. Well, I think there are different notification systems between the public and private sectors. For the definition of serious medical events, is the definition the same for public hospitals and private hospitals? If the definitions are different, then sometimes members of the public will ask why this particular incident has not been made public. So in future, will you perfect the notification system to further protect public health? Secretary, the first question is related to fees and charges. Indeed, in future, we have to consider carefully the differences in land grant conditions for private hospitals, because as a result, the fees and charges may also be different. If a private hospital is purely paying full premium for a site to operate a private hospital, then theoretically, in a free capitalist society, we should not regulate the fees and charges of that particular hospital. But some private hospitals obtained their sites at a low premium. Therefore, in future, and also at present, conditions must be set to regulate the services and fee structures of these private hospitals so as to benefit the patients. In history, we adopted different methods for different private hospitals. As I pointed out, in the past, we did not have a standardized method. Recently, when we granted 2 new land sites, the conditions were also different. I think we have to draw from our past experience. What we should include it in the conditions of future land grants for private hospitals, and such conditions will have to be endorsed by the CE and Council. Anyway, if any private hospital received a reduced premium, then conditions must be built into the land grant to benefit the patients. As for the notification system, although it's said that there are differences among the public and private sectors, the DH has tried its very best to standardize the system. Private hospitals are regulated by the DH. They are duty-bound to notify the DH certain medical events. But sometimes we're unable to reach the frontliners who may worry about the impact on themselves. So we encourage frontliners to notify us. After notification, the DH will assist the private hospital concerned to handle the event. Besides, we can absorb experience in improving future services. Well, the 2 members who would like to ask questions have left the room, so let me clarify some points first. First of all, I'd like to focus on transparency, because I'm also in private practice. In fact, for all private hospitals, they have a list of fees and charges that is universal to all. You won't apply a different list for different patients. But of course, every patient uses different services, both in quantity and quality, and doctors may charge different fees. That's why the private hospitals are saying that it is difficult to estimate how much fees and charges the patient has to pay. But in recent years, the usage rate of private hospitals has been on the rise. I believe it now exceeds 10%. Therefore, more and more patients are using private hospitals. In actual operations, when a patient asks a private doctor, the doctor will, on the basis of his own experience, the hospital does not know how much services the patient is to use, but the doctor roughly knows. So the doctor can roughly tell the patient how much money would be involved. For, say, colon cancer, the cheapest is $120,000 in a particular hospital, but in hospital B it will be $140,000. Hospital C, about $160,000. So that's how it operates at the moment. individual hospitals have their respective price list, and patients use different services. And a doctor can, in accordance with his estimation of the conditions of the patient, estimate the cost involved. Well, some operations may be more complicated, while others may be simpler. Sometimes, if the resultant fees and charges of the hospital concerned become higher, the doctor will have to offer a discount to the patient insofar as his own fees and charges are concerned. Anyway, this modus operandi has to be explained to the public such that they won't worry about unknown and fluctuating prices. Take, for example, do we actually have an example in the past 3 years of excessive charging as a result of use of obstetric services by a patient? Mr. Chairman, prices do vary. Different hospitals charge differently. Ward charges, hourly rate of the operation room. Well, these fees may also vary at different times of the day. On holidays, fees and charges may be higher. Well, if a patient chooses to undergo a certain operation in a certain hospital, then usually the doctor can tell the patient that, save for unforeseeable complications, the operational charges would be this and that. And for anesthetics, again, the fees and charges can roughly be predicted. And then the third item may be consultation fees charged by the doctor when he visits the patient in the ward. That's the visiting fee. But that can be controlled by the doctor. Some doctors will explain to the patient through his nurse the daily charge for which class of wards and the hourly rate of the operational fee, etc., etc. And normally it can be estimated how many days the patient has to stay in hospital, so the patient can calculate the ward charges. As for the operation, normally it can also be estimated how long the operation will last, so the operational fee can also be estimated. So for a selective operation, the doctor is able to tell the patients a lot of information. I think we need to do more publicity on this. I understand that more and more doctors will be making known to their patients in advance the estimated cost. But of course, before any diagnosis is given, it will be very difficult to predict the fees and charges. Mrs. Regina Ip, thank you, Mr. Chairman. I'd also like to go back to your question about industries. Dr. Ko said that as Hong Kong's medical standard is high, it was thought that it could become an industry. But a high degree of professionalism may not necessarily call for industrialization of the profession. And then you have to look at fees and charges. And just now you mentioned capacity. By capacity, we don't just mean beds. We also mean manpower. Without manpower, there's nothing you can do. So given this circumstance, Hong Kong is a high-cost jurisdiction. We're different from Thailand. I know friends who go to Thailand to undergo basic medical checkups. They have packages of services, and then they come back very happily. The hospitals are big. The human resources cost, manpower cost is low. In Hong Kong, should we sell shark's fins or vermicelli? And Dr. Ko said that there should be streaming of services and private hospitals should share out the burden of public hospitals. The day before yesterday, I attended a meeting and learned that the basic cost of a public bed is $4,000, but the patient is only paying $100 per day. So public beds are heavily subsidized. So how can people patronize private hospitals? So how are you going to address this imbalance between the public sector and the private sector? Dr. Ko, concerning industrialization, I very much agree with Mrs. Ip. I think we should consider a number of factors in order to develop this particular industry. We're not actually calling it an industry. In fact, throughout the world, in all jurisdictions, the medical sector is an industry. When compared with neighboring jurisdictions, our costs are high. But that does not mean that we cannot become an industry. Not necessarily, but probably we have to provide high-end services. Whether or not we're able to do so is another matter. As Mrs. Ip said, our costs are high, but if our capacity is low, there may be a problem. Even for private hospitals, we have to gradually develop their capacity. We have to expedite the pace of training for human resources. Only when we're able to do both that we can talk about industrialization. Dr. Ko, for the so-called double-no babies, well, tomorrow we'll be debating the education, in quotation marks, industry. Now, if we cannot meet even domestic demand, we cannot use the profession to make profits. Well, public hospitals are unable to cope with the double-no babies. And then the middle class cannot afford the services of the private hospitals. So, as a result of industrialization, the middle class will be very miserable and they complain. Well, I agree with you. I think we have to be very cautious in industrializing our medical profession. For private hospitals, in the past, in particular during the SARS outbreak, what I heard was that people say that the hospital authority should not perform too well. Otherwise, private hospitals don't have business.
If for private hospitals, part of the income is actually coming from outside the territory, this will help the sustainable development of private hospitals. In the dual-track system in Hong Kong, the role of private hospitals will continue to be enhanced. Well, I agree that we should be prudent as far as private hospital development is concerned. And on different occasions, I have given this impression to the media that as far as the 4 sites are concerned, whether they would be subject to tender expeditiously, we need to look at the market response in the first tendering exercise. Ms. Alice Mack. I agree with Secretary and some deputations in saying that the fees and charges might not be fluctuating. I recall that when I was admitted in a hospital, I was told the fees or charges for particular services. So I did have some information. We would have a rough idea when we are admitted in the hospital. But the grievances among the public is that when we patronize private healthcare services, we expect the charges to be higher. But the problem is, first of all, that there aren't sufficient beds. Recently, some friend of mine told me that he or she needed to go to a hospital for a checkup, but because of lack of bed space, my friend had to resort to the more costly beds in the private ward. I don't know, Chairman, that's what my friend told me. The second point is that even when patients pay more, do they get better services? Well, some say that the environment as a whole in private hospitals is better. But, for example, in the obstetric wards, even nurses are speaking Putonghua now. So, should we really hurry ourselves in industrializing the profession? Or should we make improvements first? As for the sites earmarked for private hospitals development, I do have expectations. Some private hospitals are charging very excessively high. I mean, not excessively, but at least the charges are high. Well, of course, you might be offering services that commensurate with the charges that you are charging, but I am wondering whether a middle range service can be provided so that patients have more options. Secretary. Well, briefly, I agree with Mrs. Yip and Ms. Mack. And after the Chief Executive has put the arrangements of mainland couples coming to Hong Kong to give birth to a halt, things have changed, and we're still looking at whether demand can be met and will be prudent in private hospitals development. And in the Chief Executive Election Manifesto, he has proposed that in future, private hospitals will be developed to cater for the needs of the middle class, and we will be collaborating with the NGOs because the main objective is to assist the hospital authority or the public hospitals so that HA patients will be attracted to patronize the services offered by private hospitals. As for the two sites that have already been tendered, well, this is already out of our control. The things have gone to the Central Tendering Board. So we should wait for the announcement of the tender result before we consider whether there is any room to fine-tune this policy. Second round, Dr. Quat. I'm still concerned about our future. Secretary, you said that in future public hospitals' pressure could be eased because patients can be diverged to private hospitals. But it's about demand and supply. Apart from land, what other factors attributed to the costly services of private hospitals? Manpower is one factor. So when there is already a shortage of manpower, how can we lower the fees and charges of private hospitals? When Mr. Leung Chun-ying ran for chief executive election, he said that there would be a series of industrialization policies. And when you have the series of policies, you can address the issues like land and demand and supply and manpower and training of staff, all in a basket. So, Secretary, are you heading in this direction or is nobody doing this? Secretary. Well, industrialization, this definitely is our responsibility. For manpower, even before July, we already started work during the last term of government. A high-level manpower review steering committee was established. Even if the work of the steering committee hasn't yet been completed, the two medical colleges are increasing the quota for medical students by 100 per year. So we agree that first of all we need to step up manpower training, and for public hospitals work should be done to retain manpower, and there should be a review on the manpower structure. It should be rationalized. That is to say, when we have population projections and the projected increase in population and also the pace of development of private hospitals, we can then have a more accurate and long-term estimation of the manpower needs of healthcare professionals. As far as fees and charges are concerned, if we're able to increase supply, for example, number of hospital beds in private hospitals, as mentioned just now, are not adequate. So if we're able to increase the number of beds with market competition, we should be able to control the surge in charges. And that should also be enhanced transparency. With more transparency, patients would be given more choices, and this is also an incentive or a measure to control the pricing at a reasonable level. Chairman, should we require the administration to give us a blueprint or a plan? Because Secretary said that it's definitely their responsibility. So shouldn't we be given a timetable so that we can explain to the public the future development? Say, for example, when should we expect to have more private healthcare facilities available? Secretary, if you're talking about development of private healthcare services, like I said just now, we need to wait for the announcement of the tender result of the two sites, together with the progress of our work in other areas, before I can plan the way forward for private hospital development. I'm not talking about private hospitals only. I'm talking about, overall speaking, the development of healthcare sector in Hong Kong. Well, then this is a big area. Well, you need to have overall picture before you can say whether 100 extra doctors are sufficient, whether these number of sites are enough, whether all these can cope with the increase in our population. Well, I need to point out that you are asking on a macroscopic level the development of the healthcare sector, but on the other hand, you're also asking about the details. For example, population projections. Now, for the overall healthcare policy on a macroscopic level, I hope that in the beginning of next year, I'll be able to give you this macroscopic view. Dr. Fernando Zhang. Well, during the first round, I asked a third question, and that is how the administration can make use of the re-registration procedure every year to address the issues raised in the audit report, and that is for hospitals run by charitable organizations, 20% of beds should be reserved, or low-charge beds should be reserved for use by low-income patients, or other issues like the lack of facilities like daycare centers as promised. So for the steering committee, when they conduct a review on the licensing or registration regime, before they come up with any findings, do you have any immediate measures to ensure that private hospitals can fulfill their promises? Now, on transparency of charges, I heard Deputations say that there is no problem with transparency of charges and that prices are not fluctuating. But at least there should be a higher transparency of information so as to reassure private hospital patients and their families. Secretary. It's very clear that on the one hand we are conducting a review on the long-term regulatory framework, and this will take approximately a year before we proceed with consultation and legislative amendments. As for existing private hospitals and the relevant land grants, conditions have been imposed, and if private hospitals are yet fulfilling these conditions, will be working with the private hospitals in ensuring that these conditions are met. But can you give me more details? You talk about the objective or the spirit. Now we're talking about existing private hospitals, where there are conditions stipulated in their land grant in the provision of low-charge beds. We will be working with these private hospitals to implement the arrangement. And we'll also be reviewing with the private hospitals on enhancing the transparency of information for patients. Now, I saw in the audit report that the utilization rate was just slightly over 10%. Oh, it's from 0 to 10%. Right. There is a bracket. And I suppose, Secretary, that within this year, the utilization rate should reach the target level. Secretary. Well, Dr. Zhang, we cannot guarantee 100% regardless of the nature of beds. But in the coming year, we're going to work with private hospitals to boost the utilization rate of low-charge beds. Dr. Kwok-Ki, are you ready for the second round? Because you were out just now. Otherwise, I will ask my question first. I'm sorry, I have another meeting to attend. So you go ahead first. Secretary, I think that industrialization of our profession actually introduces a very difficult concept. Industrialization doesn't mean that we need to provide service for foreigners or people outside the territory. And according to the information, private hospitals are offering services to non-locals, and the percentage is less than 5%. So, Secretary, you also made an interesting point about insufficient capacity. For private hospitals, operating theaters and beds are far from sufficient. I actually went to a private hospital, and I was the soonest booking available for a cancer surgery, a colon cancer surgery, is in January next year. For colon cancer surgery, the patient should not need to wait for several weeks. So it's not about industrialization. For private hospitals, 95% of the patients are locals. So we should avoid the complicated matters, and more beds should be made available as soon as possible so as to shorten the waiting list, and the charges can therefore be set at a more reasonable level.
我同意你講嘅，根本係產業嚟講呢
I agree with you, but when I mentioned industrialization is because an honourable member asked about the future direction of industrialization. Yes, by industrialization, we do mean part of the services serving non-locals. So there's insufficient capacity in that regard. That's why we have to boost the capacity of private hospitals. I believe it's not a capacity problem. I don't think you need to mention industrialization. To put it in simpler terms, you need to enhance land resources for private hospitals. Because for me, I can't even cope with my local patients. So why should I attract more non-locals? And that applies to many private hospitals as well. As for manpower shortage, you have to provide us with data on, say, a 300-bed hospital. In fact, I've repeated this question. How much manpower you need so that we roughly know the demand? Well, we can provide the data. But, Chairman, we have to point out one point. For manpower, the requirement of private hospitals may not necessarily be the same as public hospitals. Higher or lower? Well, you and I have been in private practice. You're still in private practice. I have been in private practice. So we know the situation. A private practitioner may have a day clinic somewhere else, so he may not be spending all of his time or most of his time in a hospital. But of course, the proportion of time spent in a particular private hospital varies from doctor to doctor. So it's quite impossible to have a scientific calculation or formula for private practitioners. But if you use private hospitals as units, it may be easier. For example, in the hospital authority, we can calculate how many beds there are in a particular hospital, so how many doctors we roughly need for that hospital. So we can do some rough calculation. Well, a private practitioner may have day clinics. He may also attend private hospitals. Given the principle of more work, more pay, a private practitioner may work longer hours than their counterparts in public hospitals. Well, I can tell you how many doctors there are in public hospitals, how many beds there are in public hospitals, and we have emergency beds and non-emergency beds. Then you can draw a comparison. Well, you can readily do your own calculation. If members require the information, we can provide them. Well, perhaps you should provide us with the information. Say, for a 300-bed private hospital, roughly how many doctors, nurses, and allied medical personnel we need. Well, to enhance the manpower level of private hospitals is agreeable to us. Well, sorry, Mr. Chairman, we have to travel from one conference room to another because we have to attend more than one meeting. Now, if a private hospital is using a site that is subject to concessionary premium, then in the general public conception, some private hospitals may exceed what a charitable organization should do. There are two things the government can do. One is to resume the land. Second is to require the hospitals to plow back proceeds to their services. So will the government consider these two possible approaches? Well, today, those hospitals with profits or reserves standing at $2 billion are not represented here. So I just want the Secretary to tell us whether he will resort to the two possible approaches. Well, there are two aspects here. If a private hospital obtained its site at a discounted premium, then there's a condition in the land grant. That is, proceeds must not be transferred. Proceeds must only be plowed back to the services of the hospitals. We've obtained data from all private hospitals, data for many years. Together with the Lands Department, we'll analyze the data item by item to see whether any private hospital has breached its land grant. What if there is a breach? If there is a breach, then we'll have to discuss with the Lands Department what solutions we have to ask for a remedy. Now, secondly, you asked about fees and charges of charitable organizations. If I'm wrong, please rectify me. For a charity, it is under Section 88 of the Inland Revenue Ordinance. That is, it enjoys tax concessions. Our colleagues who are responsible for taxation policies have already answered related questions. On that occasion, I heard from the answers that the department responsible for inland revenue did monitor the charities under Section 88. If the organizations do not meet the requirements, I think I heard that over 100 such organizations had their concessionary tax arrangements taken away. For private hospitals like Union Hospital, which makes profits, we know the situation. For those hospitals who operate as charitable organizations, which obtain their land sites at a discounted premium, will the government send somebody to sit on their governing committee? We all know that each of those hospitals has a board of directors, which is actually a black box. So will the government consider sending somebody to sit on their board? Another aspect is inadequate beds. I think many of our colleagues agree that we should increase the number of beds in private hospitals. In the last exercise, there were 4 sites, and we ended up with 2 only. I hope there won't be a recurrence of the Union Hospital case. That is to turn part of their site into luxury flat development. Now, in Singapore, the percentage is 20-odd%. We in Hong Kong is 12 to 13%. I hope that we can ensure that there are sufficient hospital beds such that private hospitals will no longer monopolize the market. I think Dr. Kokaki's questions can be divided into 2 parts. First, can we send somebody to sit on the board of directors of the private hospitals? At present, There's no such provision in the land grant, so we don't have any statutory basis for that proposal. But if a private hospital invites us to sit on their board of directors, we're willing to do so. But at this moment, no private hospital has ever extended that invitation to us. In future, we'll consider what additional provisions have to be included in the land grant. The other aspect is number of beds. Do we have enough beds? Now, with these two new sites, we would like to increase the number of beds in private hospitals. Of course, we cannot have all the 4 sites on stream at the same time. Manpower level may not be able to catch up. As I said just now, even before the steering committee started to work, the number of medical students per year has been increased from 300 odd to 400 odd. So starting from the year 2015-16, we'll have 100 odd more medical graduates every year. As for crowdedness, if we add new requirements in our tendering documents, will we be able to satisfy the needs in terms of specialists, number of beds, etc., etc.? You see, outside many people have already criticized us. They say that it's because of the tendering conditions that nobody came forth to bid 2 of the sites. Well, for the time being, nobody has requested a change in the land use of those 4 sites. Anyway, we have to wait for the outcome of the tendering exercise. I'd like to follow up on Dr. Kwok's question. He mentioned profit transfer. Some private hospitals are making profits. So if there are transfers of profits, you have to examine whether or not land grant conditions have been breached. Otherwise, you may have to consider compensation or remedy. So what were you inferring just now? Is it realistic to require private hospitals not to make profits because you cannot guard against transfer of profits? I also asked the Inland Revenue Department, which told me that the only thing they can do is to withdraw the non-profit making status of these hospitals. But as these hospitals are making a profit, they don't mind giving up that status.
Not true. I'm not implying anything. I mean what I say. Well, perhaps I didn't make myself clear. Now we're talking about the existing private hospitals. Some of these hospitals have conditions attached to their land grant, which said that the profit must be plowed back to the operation of or investment of the hospital. The profit cannot be transferred. And in the audit report, it is revealed that the profits have been transferred partly to the leaseholder. But the reply from the private hospitals is that the profits have, in fact, not been transferred away. The profits are still being used on the area specified in the land grant. And whether this allegation is true or not, we're still looking into it. We are looking into whether they have contravened the land grant conditions. If they have not, then their explanation would be a plausible one. On the whole, if the government is of the view that the hospital is not abiding by the land grant condition, then we will see what can be done. But in future, we will impose stringent conditions such that the profits would be plowed back to the investment of private hospitals. Secretary, after discussing with the land department, will you inform us of the outcome? This is a very simple business operation model. A private hospital generates huge profits, and in its operation, it is required to procure services or equipments from outside. And during the procurement process, if the hospitals concerned procure services or equipments from the associated companies or the relevant companies, they could already make a profit. I cannot say at present in detail whether this is indeed happening. We are still looking at the information. But the answer to your question is yes. Once we scrutinize the details, we will let the public know, let members know the result. Well, earlier, we asked about taxation matters, and we were told that it's confidential. So as far as transfer of benefits and the accounts are concerned, the private hospitals will not disclose the details to us. So are you going to let us know the outcome of your discussion with the land department? I cannot say anything on behalf of the Inland Revenue Department, its operation, or the communication of the department with relevant parties. What I'm saying is something that's different from taxation matters. We are talking about compliance with land grant conditions. If in our view, the transfer of profits is not complying with the land grant condition, we will look into that, and this is what we are discussing with the Lands Department, and this will also be passed on to the Audit Commission. Dr. Kwok, Chairman, I'd like to ask a question. Now, at present, a small number of private hospitals are making their accounts public. Does the administration have the responsibility of compelling these private hospitals run by charitable or non-profit making organizations to make public the financial reports? Because this is public money. Land is public resources. If private hospitals are unwilling to disclose these important reports, how can we give an account to the public? Secretary, as I understand, if private hospitals obtain the site at a low premium or discounted premium, there will be conditions attached, and we require that they provide an audited account to the Department of Health. Now, my question is, how many hospitals at present are disclosing their financial reports to the public? I cannot answer you on this. But this is the most important thing. The public should have the right to know. We're concerned about the operation of private hospitals. So does the administration have the responsibility of making public this information? First, you require them to give the audited account information to you. And what about public access? Secretary. I think things are very clear. As the regulatory body, we have the authority of requiring this information. Now, second point, if we're talking about making public this information, then it should not be confined to private hospitals only. It should apply to all non-profit organizations. But are they doing it or not? I really cannot answer you right now whether there is a requirement, whether there can be a requirement for them to make public their accounts. Well, this is not something that I can answer you on the spot. You're talking about all non-profit making organizations and whether they have the responsibility of disclosing to the public their accounts, and I can't answer you on this. Supplementary question, any? Well, Chairman, even if he can't answer my question now, I hope the administration could submit papers afterwards, because LegCo members are asking this question on behalf of the public. Second point, according to the Secretary, and I welcome this, by 2015-2016, there will be additional manpower as far as doctors and nurses are concerned. And it takes a long time to design and develop a private hospital. So at present, we're experiencing a shortage of beds, and like Chairman has said, he also has to wait for a month before he could perform a colon cancer surgery. So whether the remaining sites would be put up for tender very soon. Now, about this tendering exercise, the administration doesn't just look at the tender sum, but also some other conditions like service deed and service standards. But my concern is, well, it's easy to make promises on services, but if they cannot fulfill the promise, you won't be able to get back the site easily. Well, if it's profit making, then it will not be subject to regulation, but this is not what the public wants. So what experience is the administration learning? At least 2 operators, I don't know whether they have submitted the tenders, but I wonder if the administration would impose more stringent and detailed regulations. And the other point is whether or what weight will be given to the service pledge or performance pledge, Secretary. Now, it's exactly because of the latter part of what you said that I cannot answer you on the first part of your question. We need to look at the tender results for the first 2 sites. If I don't know the market response of the first 2 sites, I cannot answer your question. So we have 4 sites. We will be putting them up for tender in order to increase private healthcare service capacity. But about the performance or service pledge and whether we should fine-tune the requirements, I really cannot answer you on this. What about the tender results? It will be available in the first quarter, no later than the first quarter of next year. By then, will it be the whole tender results? The whole tender result. Dr. Helena Wong. Thank you, Chairman. Sorry, I had to attend the other meetings just now. I wonder if this question has been asked. Point 16 in the paper. It says that public healthcare services have been and will continue to be the cornerstone of our healthcare system, acting as the healthcare safety net for all remaining strong and robust through continued investment and commitment from the government, but at the same time, the policy should also facilitate private hospital development. So on the one hand, more choices should be given to patients, and on the other hand, the administration or the government, the public hospitals cannot accommodate so many patients. So some patients must be diverted to private hospitals. So it seems that public healthcare service is the cornerstone. It is supplemented by private healthcare services. We understand that public resources are limited. Land resources are also public resources, and they're limited as well. So on the one hand, the development of private hospitals can allow patients to be diverted from public healthcare system. On the other hand, this will cause a brain drain of public doctors and nurses. So what can be done to ensure that whilst developing private hospitals, the quality of public healthcare service will not be sacrificed or compromised? In terms of recruitment terms, working hours, salaries, what can you do about them to retain these professional elites in the public healthcare system so that they won't be attracted to join the private sector? Because otherwise you will see a serious imbalance. For those who can afford private services, they can enjoy the good service of private doctors, and for those who cannot afford costly services, they need to rely on the public healthcare service. But the famous doctors, etc., they've all gone to private hospitals. So what can the administration do to ensure that such talents are retained in the public healthcare sector? Secretary, we need to ensure that there is a healthy demand and supply situation. At present, it seems that there is a greater demand and there is competition in terms of manpower between the public and private sectors. And this is very important. During the last term of government, we already established a steering committee on medical manpower planning. And the service environment is very different. We cannot compare apples with oranges. For doctors working in public hospitals, some of them are committed to serving in the public healthcare sector. I can tell you that many senior public doctors are working in public hospitals until they retire. So we need to ensure that first of all, that public healthcare services is a safety net for all, and it is a cornerstone of our healthcare system. That's why we have put this in our paper. We need to establish that. And secondly, although there is increasing training of manpower in the private hospitals, the public hospital is still playing the main role.
Recently, public hospitals have done a lot to retain manpower in terms of promotion prospect, for example. So we have to look at overall manpower supply and demand. Secondly, in public hospitals, through working conditions, training opportunities, development opportunities, etc., we'll try to retain those personnel who have all along been working in public hospitals. Well, actually, the scheduled time is up. I'll extend the meeting by 15 minutes. I'll be short. I would like to know if there are statistics to show how many doctors and allied healthcare personnel had been lost to the private sector. And what about the effectiveness of your retention program? You can give us more details later after the meeting. I think we've received those data previously. Oh yes, we will provide you with the wastage statistics. I'd like the Secretary to explain more this issue. For the land sites for private hospitals, it should not exceed 1 hectare in area. Why such a big site? Will you worry that after some time they'll use part of the site for other uses? I think you have 2 questions. No, I only have 1 question. I just want you to provide me with statistics on existing hospitals. Oh, you're asking for data. My question is, why are those 4 sites so big? Will you worry that in future the hospitals will use some of the land for other uses? Well, in fact, the CE in Council has already made a decision on this. Land sites earmarked for private hospitals cannot in future have land use changed. No, you won't allow them to change? Well, the policy of the EXCO is that the land use specified in the land grant, say hospital or whatever service, will not be allowed to be changed in future, and will tell the private hospitals as such. Secondly, the number of beds and the plot ratio will be increased in terms of standards. Modern hospitals are different from those in the past. It's not just about beds, laboratories, blah, blah, blah. More and more, hospitals will provide a lot of other services, thus leading to the demand for increased land, say machinery, large diagnostic equipment, etc., etc. So more land will be required. In the past, we did not have daycare centers, and now we have a lot of centers, diagnostic centers, skincare centers, etc., etc. So, for a modern hospital, it does not just involve beds. Therefore, a hospital will require more land when compared with the past. Secretary, can you supplement on this? Number 1, in future you won't allow the hospital to change the land use specified in the land grant. But when government changes, when social environment changes, that can also be changed. Because the first thing the land developer will do is to seek a modification of land use. Well, let me clarify. It's not the land use in the land grant. This is an EXCO policy. That is, the land use specified in the land grant will inform potential applicants that in future we won't entertain any application for land use modifications. Well, but the EXCO can also change. Do you know who will be the CE after 2017? So you say this provision cannot be changed. At most, you can say that for this EXCO, This cannot be changed. Well, let me ask you the same question in a reverse way. Say for the typo site, only 1 hectare of land will be sufficient to develop a modern hospital with all the modern equipment and facilities. Now, for the residual land, if you do not allow them to change the land use, will you be wasting the land? For Union Hospital, for example, with just 1 hectare, they can build 390 beds. And then for the remaining half of the land, they built several blocks of private residential flats. Well, I think we should view it in the other way. In future, when we launch new land sites, we should examine the area of the site very carefully to see whether it is sufficient for a hospital with a certain number of beds. Now, I agree with you in that regard. But concerning tendering results, I really cannot answer your question because we don't know the tendering result. Oh, I understand your answer. You're saying that previous tendering exercises are not your duty. I think we can adjourn our meeting. Oh, Dr. Kwok? Well, after listening to the Secretary, I was alarmed. In 2002, the EXCO announced that all newly granted land have to satisfy 2 conditions: 20% for charity, all monies for the hospital. But in just 10 years, many private hospitals acted against that. You told us that the EXCO has made a decision that cannot be changed. Sorry, it's very difficult for us to have confidence in what you said just now. For the few sites that we're talking about, many people worry that their area exceeds what is needed. Union Hospital is an example. So the question is reasonable. In the tendering document, you mention a site that is big enough for a private hospital. You have to make sure that in future, the private hospital concerned has to use up all the land instead of modeling on the Union Hospital example of leaving half of the site for private residential developments. A new EXCO may adopt a new policy. We'll say if a hospital tells you that its development is to be phased, they'll build half or a third first. Well, what I can say is that I thank Dr. Kwok for pointing out our difficulty. I can only say that at present, this EXCO has this policy and will try our very best to execute that policy. I think it's almost time for us to conclude. Friends from the private hospitals, thank you for coming today. We all agree that we're discussing matters, not people. We hope that for both the public and private sectors, we can have long-term healthy development. We're not targeting any individuals. And Secretary, please provide us with the written information and follow-up answers after the meeting in relation to, say, financial arrangement. Thank you very much.